Today, you will learn that hypoglycemia in the neonate is actually less than 50. And everyone else, try to match the symptoms to the patient in blood sugars less than 70. In the patient who's able to take orals, try oral glucose like sodas, juices, popsicles. In the patient who is not able to, or you need labs for other reasons, consider dextrose containing fluids such as D10, D25. In the patient who's unconscious or seizing, GCS less than 7, okay, then you can use the glucagon. And there is a new way to deliver glucagon. It's through the nose.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Julia Magaña
and Sarah Medeiros. Welcome back to EM Pulse.
Sarah, we just had our last Push Dose Pearls episode with Chris Adams, our ED clinical pharmacist.
Yeah, and Chris has moved on to greener, colder pastures up north. But fortunately, we have another amazing ED pharmacist at UC Davis to talk about meds and ED.
Today, we want to introduce Haley Burhans. She is a clinical emergency medicine pharmacist at UC Davis, and she is going to be our new Push Dose Pearls expert.
So welcome, Haley.
Thanks, guys. I'm so excited to be here.
Okay, Haley, I feel like I see hypoglycemia in kids fairly frequently. You know, as a specialty, we tend to be really worried about hypoglycemia for many reasons. Maybe it's because my own blood sugar drops on a shift and it's hard to function well when your sugar is low. But there's also that dreaded hypoglycemic seizure. At what blood glucose level or threshold should ED providers really get worried about hypoglycemia?
Yeah, I think that this is a great question because when you look in the literature, there's not strong evidence to say everyone at 60 is going to be dysfunctional. And I think, if you've gotten labs yourself, you've probably seen that your blood sugar can drop pretty low. But I think especially for certain patient populations, when they come in with critical illness, anytime someone's below 70, I'm starting to question, should we intervene? I think in the 60s, especially if they're coming into the ED and something's going on, I'm more inclined to act and provide some sort of intervention.
Especially if that intervention is something like, here's a cup of apple juice or here's a popsicle. Like, that's a fairly benign intervention.
Exactly.
For something like that. But what about age-based? I mean, in pediatrics, we definitely have a different number for the neonate, that fresh baby that just popped out versus the young child. Tell me how age comes into this for you.
Yeah. So I think to your point, knowing, kind of our physiology and younger kids are more dependent on us supplying them with dextrose. And so the younger they get, the more I'm willing to err on the side of caution and just make sure that we're supporting their kind of metabolic demands to avoid some of those more serious complications, especially when we're in a controlled setting and we can monitor their glucose and make sure we're not overdoing it. So again, I don't think I necessarily have strict cutoffs, but I think, those lower numbers and the younger they are, the more inclined I am to kind of provide some sort of support, especially since we can have a treatment plan to monitor.
Yeah, Haley, for me, I really think of those first 24 hours of life, really some people say up to 72 hours of life in that neonate, as less than 50, which is like legit low as abnormal. And I'm starting to get a little bit more aggressive because you can have a blood sugar of like 55 in a neonate and that just be normal. And then in older kids, less than 60. And again, it's like putting that clinical picture of how you're acting. If you have a child that has a blood sugar of 65, 70, and they're peaked and laying on the bed and barely interacting with you, then treat the glucose, right? And if you have a child who's like 57 but is bouncing off the walls, I'm not jumping up and running and throwing an IO in that child to give them some dextrose, right? Like, it really is like, I think that combination of the clinical picture plus the number. But I think it's important to know that the neonate, their blood sugar can be lower and that be normal. I'm just wondering, I don't treat older people, but is this a thing in elderly? Like, are they like neonates also and can have lower blood sugars?
I mean, I see it in the ED in our older patients, often more so with our patients with diabetes or also patients with renal failure.
Yeah.
So if somebody's kidney function has acutely worsened and they're still taking the same amount of insulin, then we'll sometimes see hypoglycemia from that.
Sure.
Other thoughts, Haley?
Yeah, I completely agree. I think there's some of our cute, elderly patients who kind of only eat like one meal a day. And so if they come in and they had dinner, their last late dinner at like 4 p.m. and they come in at 7 a.m. and their glucose is just 60, but they're like totally fine. I'm kind of like, well, it's been a while since you ate anything. So I'm not super concerned. So I think it's similar to the neonatal phenomenon where I'm like, this is just your normal for where you're at today. And that's, something that we need to assess. But I do feel like, with older patients, it tends to be a harder picture to figure out if it's contributing to their symptoms or not.
Yeah.
So I think we do tend to kind of just give them a little supplement just to rule out that that's not kind of contributing to whatever brought them in.
The other thing in patients who have longstanding diabetes is that sometimes they don't get those classic hypoglycemia symptoms until they are much lower. So we do have to be careful about that because if you have a diabetic patient whose blood sugar is 50, they may not feel it yet as their, kind of disease has progressed over many years.
Especially if they're on other medications that can mask the symptoms. So, we always talk about beta blockers kind of masking the heart palpitations, the sweating, and then, it makes it even harder for them to catch.
So let's talk about some of the common causes of hypoglycemia in the ED. And does the underlying cause impact the treatment decision?
Yeah, I think for us, for me as a pharmacist, I'm always asking, is it medication related? And if it's medication related, it gives me a pretty good idea of the types of support and how long I'm going to have to provide support for those patients. I think it becomes a little bit more challenging for people that have chronic conditions that come in and may have just lower glucose levels, like liver disease or some of those other things where maybe they just live a little bit lower and that's kind of their new normal. So I definitely think kind of working closely together to address what we think the underlying etiology can also help dictate whether or not we provide more aggressive intervention.
Okay, what about the critically ill patient? What is hypoglycemia? What's our target normoglycemia in those intubated septic patients? I remember chasing this as a resident. Where are we at now in that status?
Yeah, I think evidence-wise, the NICE sugar trial tells us for critically ill intubated patients, 100 to 180 is going to be kind of like your sweet spot in terms of outcomes. We know hyperglycemia is really bad. I think we talk about less. What do you do in that 70 to 100 range? Is it worth, kind of pushing their sugar? Do we just monitor? And so I think that can definitely be a little bit more difficult to manage, especially if you have kind of one of those chronic patients that has liver disease or something else where they're just, if they're not being fed, they ride a little bit low. So I think as a pharmacist, this is something that we're very fortunate at our hospital. We have dietitians where it's kind of recruiting those resources early, but we know that they have, increased metabolic demand. So again, I think me as a clinician, if I see someone who's acutely intubated and all of their glucoses are in the 70s, I think it's worth a conversation of, do we start some dextrose in their maintenance fluids? Because we know that that's probably not going to make them above 180, but it may provide critical support kind of in this transition time until we can figure out when they're going to be able to eat next.
I thought those studies were really interesting that found that you really are better off to have that more permissive, larger range of blood sugars and instead of trying to have that tight control, that there was no change in outcomes, but there was a change in resource intensity, and you were more likely to become hypoglycemic trying to keep it in that tighter range than the permissive 100 to 180, or some studies 120 to 180, whatever, like you pick that larger range that's okay. So I thought that was a really nice thing to find out, kind of like akin to the temperature control studies in critically ill patients, that maybe us trying to be a pancreas or us trying to be a hypothalamus, like we're not quite so good at trying to be really tight on those things as a group.
All right, so let's talk about some of the most common causes of hypoglycemia in the ED.
Yeah, so me as a pharmacist, I always, of course, think about medications first. So is it medication related? And that can help us dictate potentially the onset of their hypoglycemia or how long it's going to persist and what kind of treatment we provide. For patients that take sulfonylurea, is actually giving them more glucose will make their hypoglycemia worse. So kind of knowing those facts can be essential to us making a treatment plan. Other than that, I think there are other reasons, obviously, that people can have hypoglycemia. So is it an underlying medical condition? Is it, that they have chronic liver failure, and so they just kind of don't really have good glycogen stores and they live a little bit lower? So I think it's really critical as a team that we kind of figure out what are our potential etiologies and then make a plan from there.
And most of that, from your perspective, is done from a good history and medication review. Is that fair to say?
Yeah, absolutely. There's, unfortunately, none of these medications we can't get levels on. We can't detect otherwise, which kind of is what makes insulin really scary for a lot of people. So yeah, it's going to be the history, family members, those sorts of things. Medication fill history can be helpful, those sorts of things. Medication fill history.
In kids, most of the time hypoglycemia is because they're just not eating, right? Like they've been vomiting and they're like, oh, when I eat, it hurts. It makes me throw up. So I'm going to not eat. And, there's some logic to that. But that's most of the time why kids get down into the hypoglycemic levels. But we also have some weird congenital stuff that can show up and that they can acquire. And those illnesses, stress out the body at that time. And that's when we're able to find out like, oh, you have this weird metabolic syndrome. So in kids, we tend to, if we see a peripheral finger stick blood sugar of less than 50, you draw a serum blood sugar. If that is less than 50, you draw and send critical labs, and there's a whole list of them that you can find online and we can put into our show notes as well. But that kind of helps to look for the cause as well. You do want to draw those labs before you treat. So usually what I do is blood sugar, peripheral stick, less than 50. Okay, at the same time as placing an IV to be able to give dextrose, I'm going to draw a BMP. I'm going to draw my labs that will help me find the cause and send them only if the serum is less than 50.
So what are the primary treatment options for hypoglycemia in the ED, and how do we choose between oral, IV, IM, et cetera?
Yeah, so I think, bucket one is going to be oral intake. Can they just take glucose tablets or juice or whatever you have readily available in your emergency department? And then if oral is not an option, then we're talking about either IM glucagon or IV dextrose supplementation. And so, I think they're both are safe and viable options with some considerations. So, IM glucagon, first of all, no one really likes IM injections. So it's not a great patient experience if they're awake and living through that. So that's always a consideration. Our hospital product, actually, the vial has to be reconstituted with sterile water. So sometimes that additional step can cause some delays in therapy making it to bedside. So it kind of depends what product you have available. It can also cause nausea and vomiting, which, we just talked about for kiddos. If they're already nauseous and vomiting, giving them some glucagon and making that nausea and vomiting worse for about an hour, if not longer, is also not a fun time. And then, IV dextrose, I think, is readily available at most emergency departments as a pre-filled bag. If not, you have 10% dextrose or 50% dextrose in kind of those ampules, sometimes that are pre-filled that we use in like code carts and stuff. So I think it's really determining if you can get an IV. I think giving someone IV dextrose is more closer to physiology, and it's also going to be a little bit more controllable. IM glucagon, you can actually have some variable responses. So if someone doesn't have good glycogen stores, like that kid that maybe hasn't eaten in 5 days, or a chronic liver failure patient, or 90-year-olds who just don't eat a lot, you might actually not get a very good response with IM glucagon and maybe just some of the side effects. So I think, doing IV resuscitation can be a little bit more controlled and a little bit more closer to mimic physiology. But obviously, if IV access is going to be a huge delay, there's no issue for me as a pharmacist with just going with IM glucagon until then.
My basic approach is like if they're awake and talking to me and they'll take PO, then start with PO. And then if they are in that I'm refusing to drink or can't, but I'm still maintaining my own airway and not seizing, then I'll place an IV and give dextrose that way. And if your GCS is less than 7 or you're seizing, then I just go for the IM glucagon, which, by the way, is very real with that vomiting. That is not a joke.
Yes. Yes. We always have, I think we still have some services that recommend, or we in the ED will even try it too, if someone has stuck in their throat and they want to give IV. And when residents patients order it for the first time, I'm like, they're going to throw up and they're like, oh, I hadn't thought about that. And I'm like, that's kind of how it works, is to get it out, is to do that. So yeah, it's very real and it's very uncomfortable.
Yeah. What about D50 versus 25 versus 10?
It's really interesting. I actually recently was looking at this, and there are some pre-hospital studies where they kind of looked at patient outcomes, difference between D10 and D50. They didn't feel like, in terms of patients that were symptomatic, there was any difference in time to resolving their symptoms. Really, the main thing that they saw was that patients were more hyperglycemic by the time they got to the ED when they were resuscitated with D50 versus D10. And so I kind of like to talk about this as a pharmacist because D50 is actually really hyperosmolar. It's something that I think we can really easily forget. But the osmolarity is roughly 2,500. And so for kiddos, a lot of their lines are smaller. The maximum amount of osmolarity we put through it is less than 1,000 is what we shoot for. So for kids, we dilute it all the time, but still sometimes for our older patients, we put, a really small IV where we can get one because they don't have great vasculature. So I think there are some patient-specific considerations and not just the resuscitation standpoint of, resolving their symptoms or the number. That I think if you're in a resource environment, it's always kind of good to err on the side of using D10, which is closer to physiology and less likely to cause things like extravasation, if possible.
And the actual dose, Haley, how much do you recommend?
Yeah, so for kiddos, we always do weight-based. So depending on the product that you have, we kind of shoot for 0.5 gram per kilo to 1 gram per kilo for our kiddos. For adults, I think that we don't necessarily err on the side of weight-based dosing. We just kind of tend to give kind of boluses at a time. So anywhere from 10 to 20 to 30 grams at a time, and then just kind of rechecking their glucose every 15 minutes.
So if it's D10, then I'm going to do 2.5 to 5 mLs per kilo. Or if it's D25, I'm going to do 1 to 2 mLs per kilo of that D25 fluid.
So there's been a growing interest in intranasal glucagon for the hypoglycemic patient. Can you share some insights on its effectiveness compared to traditional routes and whether it's being used in the ED setting?
Yeah, absolutely. So the data that we have for intranasal glucagon compared to IM administration, onset pretty close. So 13 minutes for IM, about 16 minutes for intranasal. Clinical outcomes didn't really differ at 30 minutes for patients in terms of improvement in their glucose. So I think when you're looking at the straight, pharmacodynamic and then outward effects, they're pretty similar. For patients that have type 1 diabetes, children greater than 4 years old is what the recommended package insert, the cutoff for children greater than 4. They say the peak effect takes about 60 minutes. For adults, the peak effect hadn't been achieved by 90 minutes. So I think that's kind of interesting in terms of a little bit of a difference from the intranasal. I don't know if it's necessarily the mechanism or just how the product had to be, kind of formulated to do intranasal administration. I don't have any experience using it in the emergency department. I actually looked up the cost of the difference of the products to see if that was a driving factor for our institution. It's relatively similar, which I think is interesting.
Yeah.
So, we kind of talked about how IM glucagon requires reconstitution, which is a whole additional extra step, and no one likes to be stabbed with an intramuscular injection. So, I think it's worth a conversation at institutions if it's easier, especially for our nursing staff who's already juggling a lot of things, to just do intranasal administration. So I wouldn't be surprised if there tends to be a push to get people a little bit more comfortable to use it in some of these settings.
I mean, anytime you can take a needle out of the equation, especially with somebody who's seizing and moving around in front of you, I feel like that just risk to the person giving it. As someone who has given an IM glucagon shot to a seizing patient, I can tell you I would rather go intranasal.
Yeah, I think as a pharmacist, some of the hesitation is there's really only 1 or 2 manufacturers. And so if you switch over to that product and then there's a shortage, then you're retraining your staff that they have to go back to IM. So
Fair enough.
Yeah, that's a factor too.
After treating hypoglycemia, what are the next steps?
Yeah, so I think if you're using glucagon, it's remembering that we're relying on your endogenous glycogen stores to kind of serve as a bridge. So we still need to give them some sort of glucose, some sort of carbohydrates, whether, that's through the IV, which I'm going to guess is 99.9% of the time, especially now that we made them a little nauseous. So I think it's still important as a team. We remember we still need to get access. We need to do the things that we need to do in terms of labs, and then we need to prioritize some sort of dextrose administration. So I think, as a team coming together, do we need to prioritize some boluses and then an infusion? Do we feel like the patient's stable enough to just start an infusion of dextrose-containing fluids and just prioritizing that treatment, making sure it's administered in a timely manner after glucagon administration?
So just to follow up on that, for patients with liver disease, is that a consideration in terms of whether you should even use glucagon?
Yeah, I don't think there's been specific studies about administration because of where people are kind of at in their disease activity. But if, for me as a clinical pharmacist, if someone says, this chronic liver patient who's fairly along in their disease is hypoglycemic, should we give glucagon? I kind of just say skip it. Let's just prioritize the IV. Let's do some IV dextrose resuscitation because ultimately, one, they're going to need it anyways. And two, I'm not really sure about the effects. Now, that being the caveat with some of the patients that Julia has brought up, if they're seizing or they're, super critical and it's we kind of the kitchen sink is appropriate to try, then I'm all for it.
Yeah.
We don't need to skip it. But if they're relatively stable in terms of we just recognize that they need some dextrose supplementation, I kind of just skip over the glucagon and say, let's do something that we know is going to work.
Yeah, I definitely am always hesitant to use glucagon personally. Although it is interesting now that we have the intranasal version. Okay, well, I think that wraps up our discussion on hypoglycemia.
Yeah, and my blood sugar is getting a little bit low, so I think I need to go eat a chocolate chip cookie.
Well, Sarah, actually, we do have some chocolate chip cookies here. Any excuse for a cookie.
So thank you to our department for having pharmacists like Haley around.
And thank you to OM Production for making these yummy cookies.
So until next time, stay curious, stay inspired, and stay tuned.
Good cookies, Orlando.
Very good.
The opinions shared on EM Pulse are those of our hosts and guests. They don't necessarily reflect the views of UC Davis Emergency Medicine, UC Davis Health, or any of their parent organizations.